Professor Jean, okay, the
yeah.
floor is yours, okay, over to you. All right, thank you very much for joining us. Yeah. So
Yeah. First, thanks for invitation from Dr. Ho and Dr. Johnny. Yes, we are old friends. Yeah, so very happy to have a chance to talk about my lecture. Yes. So, for many from Dr. Ho and Dr. Johnny. Yes, we are. Oh, yeah. Sorry. Okay. Hello, everyone. Yes, good evening. Yes, I'm very. It's my pleasure to be here to share my standpoint of the early orthodontic treatment for mandibular retrognathia. The diagnosis and the therapy based on the growth and development. So, thanks, Doctor Ho. Give me introduction. Yes. So, yeah, yes, I'm Dr. Jin. I'm from Department of Orthodontics, School of Stomatology, the both Military Medical University of China. Yes, I work in my department maybe 26 years as a orthodontist. This is my team. Yeah, they are students, doctor degree and master degree. Yeah. Now, let's begin this case for my lecture. Yes. You know, she is a girl of 12 years old, and the chief complaint is a small chin. So from medical history, we found she had a facial injury, facial injury at 6 years old. So it's very terrible. And this facial examination, I found we found the symmetry face with sort lower shadow face, incompetent lip, about the profile, maybe convex profile, retrusive mandible, average mandibular plans angle. Intraoral photograph we found here. Maybe we found three incisors. No. She is in the position of mixed dentation. The incisor protruded from the arch in upper jaw. There were the incisors missed in the lower arch. AMB is the 6.2, maybe is larger than normal. It means maybe she was mandibular retrognathia. You can see the upper incisor. The upper incisor were labial inclined, and the lower incisor were lingual inclined. This is a panoramic radiograph. We can we could see there was a miss the incisors James. We got the message from the phalange radiograph was that she was at the peak of growth, and the left condyle was anterior displaced. We have the criminal facial analysis. CF difficulty total 55.5. Space analysis is difficulty is 7. So total difficulty 162.5. It's a very difficult case. So about diagnosis, maybe angle class 2 division 1 and the skeletal class 2 relationship. So we made the treatment plan. One is align to level dental arch. 2 is to promote mandibular growth and development by using inclined gap plan, and then expand the lower arch with vertical elastic and class 2 elastics. After treatment, we found the chin is very well, and the mandible maybe is forward and have some growth. Intraoral photos showed the normal overjet, overbite, yes, and the incisor in upper jaw, upper arch is very well. You can see those the 3 incisors, and they are class 3 relationship molar relationship, yeah, class 3. That models you can get the detail about the treatment. Yeah, yes, you can see the overjet, overbite. And then under the class 3 of molars and canal. You can see this condyle is normal. This panoramic radiograph is very well. And you can see, pay attention to this mandible. It's maybe have a growth and a development. Cephalometric analysis and superimposed tracing, you can see the mandible growth. For maxillar forward growth, mandible forward and downward growth. and backward and downward rotation, and the extrusion of posterior teeth. So now there are a question. What is the truth of mandibular retrusion? McNamara study of class 2 malclusion indicated that the most common competent in class 2 sample population is mandibular retrusion. As he divided the mandibular retrusion into skeletal mandibular retrusion and positional mandibular retrusion. So for skeletal mandibular retrusion, maybe it's so the deficient growth and development of mandible because of some skeletal factors. For positional mandibular retrusion, it's so the retrusive position of mandible because of some positional factors. The total orthodontic treatment must coordinate with the normal pattern of growth and development, and try to improve and compensate the deficiency of it. I think that this sentence is very important for everyone's treatment, everyone's correct teeth. Yeah. The earliest research of criminal maxillofacial growth and development was initiated by Professor Bolton from Case Western University. Yes, in 2001, I had invited this lab. It's very well. Yes, this research is very important. I think yes. The study began in the 1929 and ended in the 1959. A total of more than 6,000 experimental subjects were collected, and a total of 209,000 X-ray were taken for the cephalometric analysis to study the normal pattern of criminal maxillofacial growth and development. The results of this study have made a very important contribution to the development of contemporary orthodontics. However, due to many reasons such as ethics, such large-scale longitudinal studies are now difficult to complete. Yes, now it's I think it's impossible in the world. Yes, so it's very very great. My team had a cross-section study of criminal growth. I collected 1,378 subjects, class 1, class 2, or class 3, yeah, were divided into different groups based on the CBM. The cephalometric analysis was performed on every subject of each group to find the mean value. Now let's review the cervical vertebral maturation. Cervical stage 1 means the lower border of all three vertebrae are flat. C2 to C4. Yeah, That means that the peak of the mandibular growth will occur on average 2 years after this stage. Cervical stage 2, a cavity is present at the lower border of C2. Yeah. That means the peak in mandibular growth will occur average 1 year after this stage. Cervical stage 3, you can see cavities at the lower border of both C2, C3 are present. Means the peak in mandibular growth will occur during the years after this stage. Cervical stage 4, concavities at the lower border, C2, C3, C4 are present. Yes, but the C3, C2, C4 are the rectangular horizontal in shape. Yeah, that means the peak of mandibular growth has occurred with 1 or 2 years before this stage. Cervical stage 5, the concavity is at the lower C4, C2, C3, C4. At least one of the bodies of C3 or and the C4 is squared. That means in mandibular growth has at least 1 year of this stage. Cervical stage 3, the concavity at the lower C3, C2, C4. One of the bodies of C3, C4 is rectangular body set. That means mandibular growth has ended at least 2 years before this stage. This chart is the comparison of mandibular growth and the development of different malformations in male. According to our study, difference male, yes. According to my study, that the comparative analysis of mandibular growth in male, yes, we found that the differential analysis showed that the growth and the mandible in male class 1, 2, or 3 subjects increased significantly during CS1 to CS2 and CS3, CS4, indicating that the rapid growth of mandible appear in the CS1 to CS2, CS3, and CS4. For lower facial head, is AS to ME. Yeah, class 1 has a peak of growth and development in CS1 to CS4. For class 2, the growth is more significant in the CS1 to CS2. Class 3 has a significant growth in CS3 to CS5 stages, and the increment of mandibular growth are greater than class 1 and class 2. just now is the male data. For female data, it's the same trait. The same trait. Yes, means the growth of mandible in female class 1 to 3 subjects increased significantly during CS1 to CS2 and CS3 to CS4. For lower facial head, AS to ME, yeah, class 1 has a significant increase at the peak of the pubertal growth. Class 2 has significant growth in the later adolescence. Class 3 has significant growth at the early stage, and the amount of growth is larger. So, I had analyzed the Cephalometric, taking cellular point to as the orange coordinated with side for 8 version was used to measure the coordinates of the points. Yes, the NOR orbit, yes, go AMI Pogoniu, AB, yeah, point. Yes, the average values of all the measure point in the 6 CVM stage of the same gender and the same type of male person sequentially marked into the static coordinate axis using a graph pad Prim 6 software. Then all measurement points of the same CVM stage are connected in order to form a closed curve. Yeah. This picture is about criminal growth in male, class 1, class 2, Maturation, class 3, Maturation. That is female. From criminal growth, the growth of the maxilla and the mandible are coordinated from CS1 to CS6. But the growth of class 2 is more slowly regardless of maxilla and the mandible. We can see there are greater growth in class 3, especially significant in the mandible. Female and the male trends is the same tradition. In conclusion, the diagnosis and the treatment plan must be based on the growth and the development. Now, let's go back this case. At the beginning, she is CS3. Means the she is at the peak of the growth, yeah, and normal maxillary length and deficient mandibular length, deficient ramus head. So maybe make you make the treatment plan to promote the mandibular growth. And after treatment, she was the CVM CS4 and normal maxillary length, significant increase of mandibular length and ramus head. Her profile improved. So let me think about the early orthodontics and the treatment planning. When we come across mandibular retrusion, how to make the treatment plan? I think maybe firstly we should distinguish the dentation. If it's the mixed dentation or early permanent dentation, we can choose the orthopedic treatment and orthodontics treatment. Orthopedic treatment included the inclined guide plate with class 2 elastic and the activator appliance, two block appliance, front 2 appliance, Forsus appliance, Forsus spring. Yeah. If the patient have a little potential in growth, we should make orthodontic treatment plan. If the maxilla was protrusion, mandible was skeletal retrusion, we should retract the upper incisor, make the vertical control, and rotate the mandible counter clockwise. If the maxilla was protrusion, mandible was positional retrusion, we should retract the upper incisor and move the mandible forward. If there was not abnormal in maxilla, we should focus on the mandible. Then, if the patient has severe skeletal mandibular retrusion, we should make orthognathic treatment, including DO, also orthognathic combined treatment. When we found the patient has growth potential, we should find a way to forward the mandible and help to accelerate the condyle growth and remodel the glenoid fossa. It is also orthopedic treatment, functional treatment. The force was loading to the dental arch, alveolar bone, and the jawbone to promote tissue remodeling in the bone suture or TMJ and achieve giant mandibular growth stimulation. Activator is made to reposition the mandible. It makes muscular contraction caused by the myotic reflex, and then muscle contraction And then muscle and the skeletal has adaptive changes in order to promote mandible and retract maxilla. According to a finite element study, activator can cause morphologic changes in mandible by activating the masticator muscles to change the growth direction of the mandible. You can see. Another functional appliance is a twin block. Bed block, acrylic bed block promote the functional displays of the mandible to favorite position to correct the maxillomandibular discrepancy by bringing about both dental and skeletal changes. Twin block produce great skeletal effect in terms of the mandibular advancement and growth stimulation, especially in sagittal and vertical dimension, and can induce the posterior rotation of the mandible. Mandible, yes, another functional appliance is Forsus applies or Forsus spring. Yeah, according the study, the mandible is forced to maintain the forward position during functional movement. Make full use of the powerful function force generated by the masticatory movement to stimulate the growth and development of the condylus and the mandible. For Forsus, it's controversial about principle of the Forsus appliance. The effect of Forsus on maxilla from sagittal dimension, distal movement of molar, retraction of upper incisor. From vertical dimension, intrusion of molars. Yeah, different direction of force. Transverse dimension, buccal inclining of the molar and inclination of molar and arch expansion. Dental arch may be a rotation of molar. Yeah. Rotation, clockwise rotation of upper arch and maxillar complex. The effects of Forsus on mandible. Sagittal dimension, initial movement of molar, labial inclination of upper incisors. Vertical dimension, intrusion of anterior teeth, transverse dimension arch expansion. Dental arch maybe have diastema. Rotation, clockwise rotation of lower arch and mandible. About Forsus, the effects of the FFA on the skeletal relationship of the maxilla to the mandible was favorable, with the A and B angle being on average 1.74 degree, decreased annually. This improvement was accomplished with the approximately equal contribution from mandibular growth, augmentation, and the retraction of the maxillary growth. The effects of the FFA were more pronounced on the dentation and associated with the significant increase of inclination of the occlusal plane relative to anterior terminal base. Removal of the TMZ. The main goal of the mandibular stimulation of in class 2 treatment can be accomplished by three components of TMZ change. One is condyle remodeling, two glenoid fossa remodeling, three condylar position changes with the fossa. Histological studies in the animals show that an adaptive response in the form of the catalog proliferation at the posterior and the posterior superior border of the condyle, taking place following anterior mandibular retractions. Punches study and the Bajoc study for the relationship between TMZ remodeling and the vertical facial type. In untreated subjects having different vertical facial morphologies, Bajoc study demonstrated vertical condylar growth pattern in divergent subjects and the sagittal condyle growth pattern in the hyperdivergent subjects. Punches study indicates that Herbert's treatment temporarily stimulates condylar growth, especially in the posterior direction, and that hyperdivergent subjects react more readily than hypodivergent subjects. A large volume of the new bone had formed in the glenoid fossa, especially along the anterior border of the post-glenoid spine after continuous anterior repositioning of the condyle. With this bone formation and the resorption along the posterior border of the post-glenoid spine, the glenoid fossa appeared to be remodeling anteriorly. Let's talk about functional appliance treatment timing. Evidence has been gathered from the literature, suggesting that the greatest skeletal effect of the functional appliance is produced when it's used during the peak of mandibular growth. For excavator, maybe the treat time is slightly before or at the pubertal peak. Twin block during or slightly after the onset of the pubertal peak. Forsus, adolescent patients, still controversial, used for the patient result growth potential. Let's begin our next case. She was 80 years old. Chief complaint is most briefing from She had electrical rhinitis. Frontal view, she had a symmetry face with short lower third of face. Profile, convex profile, retrusive mandible, average mandibular plan angles. Intraoral photograph, class to molar relationship, increased overjet or bite. We can't see the incisors of lower arch. She was as one at the it's very young and a lot of potential of growth. You can see the mandible length and height was deficient. It means she was before the onset of the pupil peak. So we need to improve this mandible growth and correct oral habit. We use the vertebral shield to correct problems. After treatment, we got forwarded the mandible and the class 1 relationship. You can see this mandible is different. It's very well. Good growth. Yeah. Intraoral photos, you can see incisors of lower arch. Yes. Next case, she is female, 11 years old. Chief complaint is was protruded from the teeth. Medical history is normal. Facial examination, frontal view, symmetry face with short lower third of face, incompetent lip. Profile view, convex profile, protrusive maxilla, retrusive mandible, average mandibular plan angle. Class to molar relationship, overjet, overbite, deep overjet, deep overbite, and delayed loss of 85 here. Panoramic radiograph, we found that this gem is good. C was CS3 period. Mandibular height is normal. Mandibular length, but mandibular length was deficient. CS3 means the peak of the mandibular growth. So we can use the functional appliance to promote sagittal growth of mandible. So treatment plan, fix the appliance, extraction of the 85 teeth, tooth. Use Forsus to promote mandibular growth and advance the mandibular position. And retract the upper incisor and the upright lower incisor. For this Forsus, we use Forsus to forward the mandible. Yeah. After 5 months, we found this from facial photos. We found the mandible is good, and forward and downward. Her profile was corrected. We also used some elastic during the treatment. After 18 months, we got class 1 relationship of the first molar and the canine. The upper and the lower arch were coordinate. Her parents was satisfied with her profile. Her mandible was forward. It's very nice. This panoramic radiograph superimposed the tracings showed her retrognathia was corrected. The upper incisor was retracted, and the lower incisor were label inclined. 2 years later, we followed this case. A stable occlusion was got, and her mandibular position was stable. Her profile was coordinated. From this case, we found Forsus can promote the growth of the mandible. It's sorry, my computer power may be off a minute, so According to some letter, we found the factor affecting mandibular advancement. First is growth and development, means potential growth. And the joint structure of function, etiology, treatment plan, including timing, methods, compliance. Another case, she's male, 11 years old, chip complex, crooked teeth. He had asthma for 6 years. Oh, terrible. Frontal view, symmetry face with short lower third of face, incompetent lip. Profile view, convex, retrusive mandible, average mandibular plane angle. From an oral, intraoral photograph, we found the class 2 molar relationship, deep overjet, deep overbite. Model analysis, crowding, bottle ratio. Crowding maybe is upper is 8 military, lower arch is 6 military. This panoramic radiograph cephalometric radiograph showed that the A and B was larger than normal. The mandible was retrusive. According to my study, maxillary length has significant increase during CS2 to CS3, about 3 millimeter. Ramex head has a significant increase during CS5 to CS6. Mandibular length has a significant increase during CS4 to CS5, about 2 millimeter. No significant increase in the middle short head. Significant increase in the lower short head during CS4 to CS5, about 2.5 millimeter. So about this boy growth and development, we found CVM CS3, normal maxillary length, normal mandibular head, deficient mandibular length, mandibular projection retrusive. He had a great potential in mandibular growth, so we need to promote the mandibular growth and once of advanced mandibular position, improvement or improve his profile. So treatment plan, yes. So fixed appliance, extraction, 14, 24, 35, 45 teeth. By maybe use Forsus and class 2 elastic to promote the mandibular growth and advance the mandibular position. And for lower arch, maybe retract upper incisor and upper lower incisor, upright. After treatment, his mandible was forward. He got class 1 relationship, molar relationship, and the canal relationship. Overbite or deep overbite, deep overjet were corrected. From the superimposed the tracing, we can see the mandible has been forward. Post analysis showed the angle of ANB, GN, GOPOG, BPOG were increased significantly. They told us the mandible length and the lower facial head has a significant growth. Follow up 2 years, the occlusion and the profile are stable. His retrognism was corrected. So, we should make the right treatment plan according to the patient dentitions, the status of the occlusion, and the profile. The mandibular retrognism can be treated easily if we find the right time and the methods. So that's all my lecture about the early orthodontic treatment for mandibular retrognism. Thank you.
Okay, thank you very much, Professor Jean, for a very impressive lecture and sharing your impressive clinical cases. Right, hereby, I'd like to thank you from ICD section 15. So here, before I end this session, there are altogether 5 questions that have been posted. So please allow me to ask you the first question to start the ball rolling. The question number 1 is that, right, the audience like to know, what is your view of using Invisalign first in early class 2 treatment compared to conventional functional appliance or myofunctional devices?
Oh, yes, it's a good question. Thanks, Dr. Ho. Yeah. I think the simple potential of Invisalign first.
Yes.
Yeah. Okay. The simple purpose of the Invisalign first and conventional functional appliance or functional device is to promote mandible growth.